Thank you all for returning to your seats. We're going to start with something nice and easy, which is one of the questions that the doctors have brought to the team, specifically for junior doctors. If you're a junior doctor, often you'll have a ward round of 25 to 30 patients or something, and then after that you'll be given a number of jobs to do. One of those jobs for patients who are unwell or sick, or who the consultant deems is not going to be able to live, is to ask them to sign the DNAR form, as we mentioned earlier, do the first signature, and then later on, if whatever would happen. So the question is, if you're a Muslim doctor who's been asked to do that job, how should you undertake that?
So is that mandatory?
Well, it's potentially mandatory. I mean, there's definitely areas of you being able to have that discussion, just like we might have discussions about abortion, etc. There are certain ways for us to have that discussion, but I'm not sure if I'm allowed to give those answers. I think it's moral.
Well, I think if it's not mandatory, then you should, kind of not get involved and refer to some other doctor. I think that would be the best option. Yeah.
There's a degree of impracticality of the senior consultant to come into the hospital to enact that. So you're therefore the most senior person in the hospital to sign that do not attempt resuscitation form. Are you then allowed to sign it?
Well, the question would be that, is it mandatory as part of your work?
As in, you won't get struck off. Mandatory in what sense? Mandatory in the sense that if you do not sign it, you will be kicked off the doctor's register, or mandatory in the sense that...
what they are saying, that practically it is mandatory.
Oh, okay.
Let's be honest.
Well, maybe we haven't seen a clear opinion of the Mujtahideen on the issue, but looking at the overall rulings, I would say that if you're dealing with a Muslim patient, you can't do that. If you're dealing with a non-Muslim patient, then if that is part of your duty, you can do it because you are dealing with their own laws regarding themselves.
Okay, thank you. We're going to move on to ethical issues and guidance as the last topic, and then inshallah we have a Q&A, and we're wrapping up at 5 o'clock, so we're going to speak for another 20-ish, 25 minutes, and then have question and answers. So please prepare them, because once we're finished, then obviously we lose these resources we have.
Assalamu alaikum again. I thought I got carried away and ethical, because this is what I teach. I have put few topics there, but I will try to just answer two things now. First of all, for all of us to understand, so we, mashallah, have got Agha here and our ulama, and we get a lot of guidance on that. I think what we also need to understand, where is the general ethical frame come from while designing the laws and regulations in this country. So I will just put a bit of reflection on that, and then we moved on to talk about the topic of the day. Today's day is assisted dying, and so I will skip a lot of things in between, but please feel at liberty to ask any questions about that if you want to. So first debate we always have, what is ethics and what defines ethics, and is it something which is individually we decide, everybody's got their own ethics, or the society? Is it comes from families, culture, religion, secular? But one thing important, so one point to mention here, and this is the crux of the matter. When the laws, what is the job of the medical law in this country, or the West in general? We need to decide, or the parliamentarians or the authorities have to decide what is right rather than what is good. There's a big difference. Something which can be right for that country or for that nation may not be good. In other terms, because quite often we go into this debate about what will be the consequence of it. And consequentialism is important, especially if you look at the rule-making framework in the United States. So states thinks differently, Europe thinks differently in terms of ethics and even the lawmaking. In European Parliament as well as UK Parliament, one of the crux of the really top stuff is, why do we make law? And if you ask them, there is one basically litmus test. How does this law, does it make sure that we are protecting the vulnerables the most vulnerable in the society? That is the litmus test. Any law has to pass in this country. In the United States, there is a different framework, and I don't think anybody's here from the United States, so let's leave it like that. But they actually will talk about more consequences. This is how they will make. So there is slight difference in how they look at ethics and how they look at law making in these countries. And there are a lot of topics we talk about, but so where is this tension coming from, even in West? So some people think this is right, some people think this is right. And this is this person's fault, actually. Aristotle. And if you look at this picture, this is one of my most favorite things. Sistine Chapel, if anybody has been to, and if this painting is called the School of Athens. And in the School of Athens, you will find Hippocrates and everybody there. But can you see those two people in the arch? The younger one, the black bearded one, is Aristotle. And Aristotle came with this idea of deontology. And when he came in Newmachian ethics, and this became the basis of the lawmaking in Europe for centuries, and even now it is quoted. He said, whatever you do has to be right essentially. For example, telling the truth will always be right. So if you're making a law, make sure you're telling the truth. Stealing will always be wrong. So if whatever law you make sure you condemn that thing. He was an absolutist. And Dr. Syed there had about 200 years back said, no, it actually does not fit in with medical ethics or medical practice. And this is what is important for us to understand when we make our decisions. And we decided that there will be 4 prima facie principles. Why was that? And there was an X theory. Sorry, I'm trying to be as quick as possible, but just to explain the point. X theory was born about Immanuel Kant days, so basically about 150 years back. I don't know if you guys have heard of this. So suppose somebody comes at that door, knocks here, and when I open the door, they've got an axe in the hand with the blood dripping, and they're massive, 7 feet tall. And they ask me, is Muhammad Abbas in there? What should I say? Tell the truth. So they said, no, sometimes telling the truth can lead to a disaster. So you need to understand why you are telling the truth as well, not just you are telling the truth. And medical ethics is defined by those type of principles. And this is here the prima facie principle comes. On the other hand, in the United States, this theory was born called consequentialism. They said, no, we don't care about what is right or wrong. All is well that ends well. This is how the law should be made. The society's development is more important than how do you get there. And they changed it a little bit, but Peter Singer was the guy who wrote a lot about this, and medical ethics changed a tiny bit there. This is what we need to understand, because quite often we have a debate, that will never happen in the States, and that will never happen in Canada, but that just happened in France, because we think completely differently. Not completely, but when we make the medical laws, they are thought about differently in the process. So the arguments which go to the parliament even are different. And I learned a lot when we were talking about assisted dying in this parliament. But out of all this was born not born, but virtue ethics came in. And some of you will know about virtue ethics because it's a religious community. Because the virtue ethics is an Abrahamic religion's theory which says every human being is created knowing what is right and wrong. You don't need to go to university. So fitrat knows right, and it will do the right thing. So in practicing, when these principles came, they took virtue ethics a lot into account. So whatever we do, so now here comes this law in this country. Whatever law you make, it has to be beneficial for the patient. Okay, we can't do benefit, next test. It must not do any harm to the patient. Okay, we can't decide between the two, autonomy. Has the patient got capacity and they are making the right decision for making their own decisions? And it can be unwise according to law. They can make a decision which you might think is complete bonkers, but that's their right to make unwise decision. And then the justice, that I have got limited resources. We talk about ventilators. We had to treat everybody fairly. This is something important for us to understand, because when we are clinicians and we are working day to day, whatever decisions we are making, and I can tell you this, investing a lot of complaints, in my input, I have to write on what basis I made this decision. Was it following beneficence, or was it non-maleficence, or what is autonomy? I have to do that, because that, at the crux of, at the end of the day, is how our registrations are judged. Are you practicing ethically or not? Every year, doctors in appraisal are asked, what do you think about probity and professionalism? Are you, i.e., in other words, are you practicing, have you got evidence that you are practicing ethically? And this is the framework. So when the tension comes in between what I said earlier in the day, moving towards today, end of this day, we need to be able to coherently articulate why are we making these decisions in the regulatory framework that we work in. And mashallah, we get the guidance, but we have to think also clearly, can we justify our decisions? That's why the decisions like, I'm by myself, making it, lighting a DNA CPR, where do I go? What is your regulatory framework asking you to do? And that's what we will have to think. And obviously, we get a lot of evidence, but this is something to consider as well. So I will skip all of this. So these are the two very important topics to me. One was withholding treatment, which talk a lot about, and this is the collusion. Do the patients always want to know the truth? And if we do that, how do we do it? I'm sure if we share the slides, you can read it. Oops, I wrote a lot, didn't I? See, I told you I got carried away. Oh my God. Okay. First thing, now euthanasia and assisted dying. What's the difference? Everybody knows? If everybody knows, we can go home. Because this is the biggest confusion. Assisted suicide and euthanasia, and this is why this debate has gone on for such a long time. It has started in this country and most of the West. We wanted to legalize euthanasia. In UK, we pulled the debate back. We said, no, we are not going euthanasia. We cannot go euthanasia. And many countries did. Whereas some countries like Canada, okay, if I ask you this question, Switzerland, is euthanasia allowed? No, it's illegal. It's a custodial sentence there. Spain, is euthanasia allowed? Yes. So there's a difference. So there's slight differences in that. What is allowed in Switzerland is physician-assisted suicide. And when I went to Parliament, that's what I said. If you really want to do something, you go Swiss. Don't go Canada. But they decided to go Canada. And this is what the problem is now. Euthanasia actually literally means euthanize, good death. So in the old days, when you did something naughty and you went in front of the Roman emperor, they can euthanize you, meaning just basically chop your head off. Otherwise they will throw you in front of lions. So that was the difference. That was called euthanasia. I'm not saying you chop your heads off now, but this is how the word came. But these are the words you need to we need to understand when we are talking about. Firstly, it's a deliberate intervention. So earlier in the day, when I asked this question, that if I'm stopping the treatment, is it euthanasia? And people talk about passive euthanasia. But did you, by stopping the treatment, did you intend to kill them? Or not? If by stopping your intention was to kill them and bring their death nearer, that will be euthanasia. But your intention was actually it's futile or it's harmful, that's why I'm stopping it, then it's not classified in ethics as euthanasia. Because it has to be deliberate action, what you are doing. And what you do, you express intention to end a life. And it's an active act. With the physician-assisted suicide, is doctor, this is the law in this country, it will become knowingly and intentionally providing a person with the knowledge of means to required to commit suicide. So you come, ask me, I give you a prescription, but I'm not doing it. You go and take it in your own time. And then you still have to arrange, so a doctor has to be in the surroundings because if something went wrong, it can be supported. So this is what physician-assisted suicide is, which is being debated in this country, not euthanasia. And the reasons people they gave is because people are going through suffering. There are lots of pain and example. And there is enough submission made to the parliament to tell them that pain and physical suffering at the time of death is extremely uncommon, if they are receiving good palliative care. It is this fear which actually leads to request for euthanasia. And there is data from Netherlands, Belgium, Switzerland, Spain, Canada, Australia, which told us that. That what are people writing as the top one? Do you know what is the top most reason for request for euthanasia in the world, or assisted suicide? Failure to, it is basically fear of becoming a burden. And this is what I said. My worry is that if you want to make this law because of this, that the right to die will become a duty to die. Because everybody will be a burden on other people. Where are our values gone in this? As a society, I'm not just talking about Muslim or Shia community. Where are we going as human beings? If we are saying that my parents are going to be a burden on me. Because you will be exposing these vulnerable groups like MND patients and MS patients and Parkinson's and dementia patients. I am being a burden. You're throwing them under the bus without even thinking. Because, and the slippery slope argument, and I worry about that a lot. Why do I worry? Look at these definitions. I said earlier in the day. Voluntary euthanasia, I've just a quick revision. You ask, I give, you die. Okay, fair enough. We respected autonomy. But then every single country which went for voluntary euthanasia, what happened next? They went for involuntary euthanasia. You're not even asking me because you have lost capacity. So we decide, we switch you off. And I come and give you an injection. If you look at Canada, and this was the biggest issue we presented again and again. Sorry, keep on coming to Canada. Does not mean they're bad people at all. I'm just talking at this law. What they made was the law, you ask, I give, you die. Then what did they decide? No. What we need to do is actually have, what if these people cannot give consent? Okay, we'll ask you guys beforehand. So if you lose capacity, we can tick that and then we do it at that time. And you write in the paper, if I lose my capacity, please give me euthanasia. And they made it a law. I've got a big problem with that. Because the basic, simple, ethical principle of consent is, you can change your mind. And now you can't. Just because you lost your capacity. And that has been practiced. Last year there were 43 people who went without what you call advanced consent under MAID, which is medically assisted dying. Then the slippery slope, non-voluntary euthanasia. What is that? You are asking me, please don't give me injection. And we say, no, we need to give injection. We need to die. To me, it's plain murder. Nothing else. Do you think it has not happened? If we wouldn't have time to go too much in detail, but read on Wikipedia or whatever you want to search, now is it ChatGPT, Action 4, AK, Action 4. Search that. Action 4 was the law for assisted dying in Nazi Germany. And hundreds of people went through that. And I have written about it, that I believe this history is not about knowing that Holocaust happened. History is about knowing that Holocaust happened and millions of people stayed silent. Why? And my view was because Action 4 desensitized the whole population towards the idea of murder. Action 4 basically said, if you lose your capacity, you are not being useful to the society, a burden on the society, we can decide to kill you. It has happened in the history. My question is, what makes you so confident you will not go there next day? And guys, it is frightening the way the law was made. But hopefully, they are talking again and again about what will they do. So firstly, you have to remember, and this is agreed upon by all the ethicists, euthanasia is not allowing nature to take its course. Euthanasia is not stopping futile treatments. But more importantly, euthanasia is not using the medication to relieve suffering. And we are, so I'm again talking about clinical ethics. We're not talking about the religious guidance. But this is what has been agreed by different bodies in the world. That if your job as doctor is to relieve that physical suffering by using medications properly. Get your training and use it so that people are not in distress. This is the data some long time back. Again, feeling a burden keeps on coming. And this is why Association for Palliative Medicine repeatedly has rejected. Whenever we have gone to survey our members, every majority, vast majority says, we don't want euthanasia legalized. We don't want that. So people who deal with death and doctors who deal with death and dying on daily basis are vastly against it. But unfortunately, I don't know, they have gone on and asked histopathologists and radiologists to do not do these things. And they say, look, doctors are saying you can legalize it. But the people who are really dealing with death and dying, they're overwhelmingly against this idea. So what happened in this country? So well, it came, so you have got stages, first stage, that second reading went, committee stage, and now 16th May, it has gone to the reading and now it is being proposed. The legislation is going to talk about, you have to be 18, less than 6 months or less to live. Now, which speciality talks about, teaches prognostication? Do you know that? Palliative medicine. And which specialist against it? Guess what? Palliative medicine. But they're still legal. So who is going to prognosticate? We don't know hell about it. So they will just need to find a doctor who is happy to write this patient has got less than 6 months. They changed the criteria, and that's the worrying part for me. But more importantly, so and they have to have mental capacity registered with the GP, 2 separate. But one of the things which I have taken out was it has to be approved by a High Court judge. Now it just has to go through a man of legal background. So in other words, you can go to a notary, pay them the money. So the son who actually wants me knocked off, he goes to that notary, pays them some fee, and they can basically sign it off. I'm talking extremely, I know that, but the law is not protecting those vulnerables. Remember, the UK stood that we will make every law to protect vulnerables, and people like us are just feeling, where are we going? And this all has gone on and on to be submitted with evidence. The last evidence, sorry, I'll finish by 30. The last evidence which we basically did is we interviewed just under 100, I think 98 women in this country from Asian background, and we submitted that. It's submitted of publication, but we have submitted to Parliament as well. And if you go to Hansard is where the parliamentary papers are kept. You will see my evidence, because I'm chairing the committee, so it is all there. We interviewed 98 record we have got. Women from South Asian background who had been through domestic abuse. What do you think about the law? And majority of them are really dead scared that their families will push them to sign this form. That is frightening, brothers and sisters, to me. That it was, the evidence has gone back in there, and this is our biggest worry, that vulnerables, this is just one example. But vulnerables, how do you, if data tells us from Netherlands and Switzerland, that the biggest reason is being a burden on the society, how will we protect them? Do you know about NHRA 1921, National Home Registration Act? Nursing Home Registration Acts were not there before 1921. It came out. Why did it come out? Because of First World War. People were dying. So we needed homes where we could go and look after these people. Good idea, isn't it? Only one problem. The reason it came out, to take those people whose family members had died in First World War. Who talks about it now? That i.e. in those days, the expectation was, if you have a family, they will look after you. That is slippery slope. Today nobody even knows about this. 1967 Abortion Act. Why did it come out? To stop the back street abortions. Because people were having abortion in the back street, getting infected and dying. They said, we will legalize it. And it will only be done for clinical reasons. Guess what? Only 27% of the abortions in this country are now done for clinical reasons. That is what you call slippery slope. And this is why we need to protect ourselves. So I wouldn't have time. So France is another one where it has gone, now it has gone to the Senate for the action. And then across Europe, there are lots of countries which are talking about it. It's a bit lighter, so I wouldn't go much into that. But my problem is another one. The people on this side, we really want the law to be right. Because as clinicians, again, not as a fiqh perspective, my job is to look after my patients and to be their advocate and present their case. So when you talk about slippery slope, Belgium legalized euthanasia in 2002. What happened in 2012? They removed the age limit. So guess what? If I take my 3 years old, I want them euthanized, as long as they have a disease, then nobody's going to ask that child. And they can be euthanized. Netherlands did the same. Is that the way you want to take? We have to ask ourselves this question. And how do we protect those who are most vulnerable? So, last point I would like to make, and this is why, brothers and sisters, to me, I know we talked a lot about advanced decision to refuse treatment and withholding and withdrawing treatment and DNS CPR and things like that. I will very strongly suggest to all of us, this is why I have become more and more fan of lasting power of attorney. If you lose capacity, don't lose the right to live. Give it to somebody who shares your values in your family. So that if, for example, in fear, at some stage you have just said it, how many of us, even when we are well, I'm not saying all of you, but have you not heard people saying it, I really don't want to live anymore. If you are a doctor, especially working with end-of-life patients, every day you get to hear this. I don't want to live. Please give me something to help me finish my life. And when you have a compassionate discussion, it gets back and back. By just legalizing it, you are basically saying, you are here, you said it, you go this way. If you don't say that, then you get hospice care. And to me, that's a big problem. If we want to protect ourselves, and I really hope we think that if we do, we need to develop those compassionate communities among ourselves, and also to protect ourselves by something like lasting power of attorney. Thank you.
أحسن. صلوا على محمد وآل محمد. اللهم صل على محمد وآل محمد وأجل. Thank you so much. All of us have got questions and comments and points we want to share, and I think if you're an expert in palliative care, to do what you've just done and disseminate all of that information, we really appreciate sort of allowing some time for questions. We're going to open the floor up. We have half an hour, 20 minutes, half an hour left for questions. Comments, reflections, if you've learned something that you think is helpful, if there's something that you wanted to reflect upon that has been mentioned, we'd really appreciate that, because there's so much learning here, and as I said, that is the key thing. We've already picked up so much from the audience. One question I'll lead with, and then subsequently open to the floor that's been submitted, is are there specific rites, rituals, things that we should do as families, things we must do for our deceased ones? It's slightly away from palliative care, but something that maybe Maulana Rizvi, you'll be able to address for us.
Bismillah ar-Rahman ar-Rahim. I wanted to actually talk about this a little bit more, just to let you know that, we see a few things going on in our community in Toronto, and I'm sure it's happening here also. And this has nothing to do with death, but actually with the grieving process. We know that in our Sharia, there is a time and place for it, right from the beginning of paying condolence, and that also the hadith that we have from the imams, that even if you just go and show yourself in the funeral, that is sufficient. Your presence, that the family saw that you were there. And then when we come to the grieving family, one of the recommendations is that for 3 days, either the relatives or the friends should be catering to the food for them, so that they don't have to go into that daily routine. And of course, you have salat of Hadiye Mayyit or Namaz Wahshat, emphasis on going to the grave to recite the surahs. And then we have a tradition which is not really based on the recommendations of the Masumin, but looking at the tradition of Imam Hussain alayhi salam's Arba'een, we also have the Arba'een Majlis for our Marhumin, which is fine. But what I have seen gradually, especially among the sisters, and I'm not talking about London here, I see the questions coming up in Toronto quite a lot. But before I come to that, there is something which I saw a growing trend, that the family of the deceased, they will have majlis, a short majlis, with Quran and Hadith Qissa and a Marsiya, for example, every evening. Now, and that goes on for 40 days. And there's no religious recommendation for that. Basically, I wouldn't have a problem with it, but what I see is that it's becoming a tradition that those who cannot afford to do that, because when families and relatives come every day, at least they will have chai and samosa. You know, those who can afford, okay, that's fine. But there are many who might not be able to manage that for 40 days. You know, and when it becomes a trend in that way, those who cannot do it, they feel guilty, as if they are not fulfilling the haqq of their marhum or the marhuma. And so that's something we have to think. We should not overburden our own community in this way. And then, mashallah, you know, the ladies' Chehlum program at home of the deceased. I got a list once. Maulana, can you look at this? And I saw, I said, mashallah, I don't know where this has come from. You know, on the 40th day, they have a list of recitation. Dua Kumail, Dua Mashlul, Dua Adila, Dua Tawbah, Hadith Kisa, Tasbihati Arba 41 times, Astaghfirullah 41 times, Ayah Karima 41 times, Amma Yujib 41 times, Durood 41 times, Bismillah 41 times. I don't have any problem with all these things. Because the du'as are relevant for their own time, but to make that a ritual for the 40th day, you know, this is where we have to think about it. Where is it coming from? You know, it is not there in Mafati. It is not there in Tuhfatul Awam, you know, the Urdu version of Mafati. And you know, when you look at the list, Dua Kumail is recommended for the eve of 15 Sha'ban, and then of course we do it on Thursday nights. This is more the dua for our own, you know, protection and our rizq and our forgiveness. There is no recommendation from any Imam Masoom saying that on the 40th day of the marhum you recite Dua Kumail. Dua Mashlul, this is actually about a young person who was distressed because he did something wrong. This is more a tawbah for that person, especially when he, you know, misbehaved with his own father. Dua Adila is a dua to maintain our iman at the time of death. It is where that will be end of life, you know, ritual, to be you recite for the person to repeat that. But it's not something to do with the you know, 40th of the person. Dua Tawbah, or you know, Tasbihat, all these 41 times. I looked for it and I haven't seen anything in the ahadith, the sources that we have, which says recite all these on the 40th day 41 times. And so this is where I think we have to be a little bit more careful and educate our community, because death itself is a challenge for the family. You know, it is a process of grief. We don't want to overburden. One last point, since I've traveled so far to talk about all these issues, so one more point I would like to, again, a problem that we have, I noticed in Toronto, on the ladies' side. Again, in namaz janaza, you know, women also come, there's no problem in that. But, you know, after that, when the janaza is taken out, you know, if the family members, the women, want to sit down and kind of cry, immediately they are told, no, have a sabr. And immediately surah recitation starts. But give them some time to, you know, cry, even if they are crying it loudly. That is the time when the janaza is now living, you know. And so there are certain things which happen where the volunteers are really sincere. I don't, you know, question their motives or their sincerity, but you have to look at the human element, you know, and you have to let the family, you know, express their grief and emotion, especially at that time. So just a few things I wanted to just share with you.
Thank you so much. Really valuable advice for us all. We have a few moments for questions or comments. I would really welcome anyone who has any reflections. Please, Asmanti.
Yeah, I come back to that question that as medical professions and assisted dying and all that comes in, how are you going to handle it?
Yeah, please.
Well, for Muslim, medical professionals, I think the answer is very clear. You're not allowed to get involved with it in any way or shape or form. I think one of the challenges we have now in Canada, that this is now part of the system there, that the doctor has a right of referring that patient to someone else. But even in that referral process is a problem. You are helping somebody to eventually, commit suicide. So that's going to be. I know the Catholics in Canada were trying to get this exemption for their doctors. I was just looking at the documents last week. Didn't find anything like that. But if there is any process by which, if you face that problem here. If there are any provisions that because of your conscience you cannot be part of it, then you should avail that and be away from anything to do with even referring the patient to somebody else.
Thank you. The answer is quite clear. We are not going to do it. Number one, I'm not going to do it. No, that was for basically not respecting patients' wishes for withholding treatment. That's a different thing. Assisted dying. So first of all, you talked about the conscientious objection, and a few years back I was on a panel to debate about does conscientious objection really exist? Because even in abortion, you have to refer somewhere.
Yeah.
So my view on Medical Ethics Society have been about actually you are still forcing us to do it. There are practical issues with it. For example, the departments I lead, I actually, on the day one, I was asked to go and suss out from the palliative care doctors. Literally 0% doctor said, and I'm not talking about Muslim doctors, 0 doctor said, I will do it. Because everybody said, I will not. Thank you very much. The problem with that is that abortion is still, if you say, go and find somebody else, the person will get in your car, drive somewhere else. Our patients are bound and totally in the last days of life. They are not having energy to do all of that. So I can see a direct clash, and this is heading our way. So we will be having that discussion at that time. My blunt answer is, and I'm on record for saying that I will leave if I'm made to do that.
Yeah, so it will be a big decision for the doctors who don't believe in that, isn't it?
If you look at this last week's Spectator, so Spectators is the periodical journal which comes out weekly, or is it fortnightly? There's a piece in that, and I'm quoted there to basically say that I will not be able to identify hospice as a hospice if that comes in, that's forced on hospices. And Amy Prophet, who used to be the chair of the Palliative Medicine, she also said that it will destroy hospice culture.
So will this also apply to GPs, that I can go to my GP?
No,
and
GP,
say
it will. The law is not. Law is actually, we did not go into the details, but say you make a request, so we need to refer to an independent panel who will come and assess and make their own recommendations. You will still have to be admitted under a facility where there is 24 hours medical cover, who will then give the injection and then give you the medicine, stay in the vicinity to see. So technically speaking, GPs, care homes, hospices will not be able to do it anyway. But on a moral basis, we feel that we still have to make noise.
Yes, Uncle, please.
Sayyid Muhammad, please, let's just try and unravel with a greater granularity this topic of DNR, do not resuscitate certification. Shabir, my colleague, did ask you this question. You quite rightly replied, and you commented earlier as well that you've written to Ayatollah Sistani, but you haven't received the answer. But just like every question that we ask our Maraja, I think it has to be asked in the context of what we are really trying to ask, really. So let's start from the beginning. Advance directive. If I have to have absolute capacity, mental capacity, myself, that I'm making I'm requesting and I'm making a decision. So in the case, say, if I am suffering with terminal cancer, and I know that, as Syed Qamar Abbas' slide showed, that every time I might improve, but I'm keeping on going downwards and downwards, and I'm going to die. So one of the events may be a cardiac arrest. In other words, the heart stops beating, provided that I'm revived within 10 minutes, within 3 to 4 minutes in the community, and it's only 10% success rate in the community, and about 20-25% success rate in the hospital. Provided I'm revived, I will live, and then I'll carry on, and then I might get something else. I might get another arrest, but I'll finally die of my cancer. So I'm making an advance directive. So I'm saying in my advance directive that if I do get a cardiac arrest, if my heart stops beating, under the circumstances, I know I've got terminal cancer, I'm on the palliative care list, I know I'm going to die within the 6 months. When I say I do, my doctors have told me very clearly that I'm going to die within the next 6 months from their experience, and that's how you become transferred onto a palliative care list. So I then say, in that my advance directive, I do not wish to be resuscitated. I believe that it is not the doctor's responsibility, it's not the scholar's responsibility to make the decision. Provided that person has got mental capacity, I repeat, that person should be able to make the decision. So I'm arguing that DNR signing is okay for that person in that circumstances that I've explained.
See, we go a step back. You see, if there is a situation where the cure is there, then revival is necessary. But we have the scenario that we were discussing was the issue where there was no cure. And that's where, I was, as I said, I have my own opinion on this issue, but we are looking for the clear fatwa from the marja on this issue. Once we get it, we'll let it know. We'll let the group know about it. But the point is not whether it is the medical doctor who will make the decision or the scholar. Any responsible, mature person who is mentally capable of making the decision will make the decision, but the decision is guided according to the Sharia laws. So it's not the alim who is making the decision, neither the marja or the doctor. They are just telling you this is the line. The decision would be of the individual anyway. So we are waiting for that guidance. Okay?
That's from an individual perspective. So you're from the scenario you've given is that the individual takes upon themselves that responsibility, despite the fact they have the understanding of what the religious context was. Is there another DNA CPR element question that you had between the group? Just wait for the microphone.
Sayed says you offered the opinion from the individual perspective. Just to confirm, inshallah for the last time, from the clinician's perspective, is there any circumstance in a situation where someone's got a terminal illness or any circumstance at all where a Muslim doctor, Shia doctor, can sign a DNAR form in any circumstance, and does that circumstance differ if it's a Muslim or non-Muslim patient? And if a non-Muslim patient requests it, in the eyes of Sharia, not legal UK law, is it permissible to sign that document?
I think Syed has just answered, but please go.
Yeah, but when it comes to a non-Muslim patient, you can still deal with according to their own rules and regulations. But when it comes to a Muslim patient, I think you are still governed by your own, religious laws. So we have to still, as I said, we'll still have to wait. And the way the question I have worded this time is talking about even the process of CPR, breaking of the ribs and all things have been mentioned there in more detail. Not only that, I have put a follow-up question that suppose we did the CPR for a patient who there's no cure, and then maybe after one day he dies again. Is it still wajib to revive him again or not? And if that happens again, what are the numbers for you stop? So my question has been kind of a long question, and then we'll see. No, I'm just letting him know, making things easy for him. But when it comes to, because the rules would be different, especially when it comes to Muslim rules regarding themselves.
Muslim patient and a non-Muslim, or a Muslim doctor and a non-Muslim? I have problems with that.
So we're just going to invite Professor Qamar Abbas to also comment.
I think, again, I'm not talking about the fiqh, but I can give a legal and regulatory response to that, because doctors also have a duty to respond to the GMC guidance. And if they don't, GMC goes the clear attitude of punishing those doctors. So the last statement says that if a patient, again, Muslim or non-Muslim, it doesn't say that, a patient makes a valid and applicable CPR decision, no DNA CPR, is legally binding, and you cannot override it if patient has capacity, decision is specific to the situation, and it's properly documented. It will be a breach of guidance and punishable by GMC. So I just need to make it clear from my legal, clinical perspective. I'm not talking about fiqh, but just doctors need to be aware of that as well.
I think the other thing we have to always remember is that we're having a nice sanitized discussion in a lovely setting. When you're on the wards with a consultant and the others breathing down your neck, there's got to be some time for those clarity. Muhammad Abbas,
please. Can I just clarify, if possible? Am I right in saying that I just want to check I've understood this correctly? That if someone has an incurable condition, CPR as an intervention, as with other interventions, can be withheld for that individual. However, I'm not able to sign a DNA CPR in advance for that individual. That's my first question. I was just wondering if that's a correct understanding from a Sharia perspective.
We still have, as I said, we'll reserve it until we get the answer, because we're going back and again, so leave it at that.
Sure. On that note, I'll omit my next question. I just wanted to make a final comment, if possible. I think from some of the discussions that we've had today, it's very clear that many of these questions are quite complex, quite situation dependent, and there are many factors at play. And we are, as you say, awaiting still some clarification regarding the rulings on this. I think it's absolutely fantastic that CoEJ have begun this initiative, and And I'm very, very grateful to both speakers for attending and assisting and generating this discussion. Can I make a proposal, perhaps, that we use this platform to draw upon the collective experience of individuals and perhaps put together some kind of forum where we can work together to generate the right questions so that we can seek the appropriate advice from our ulama, and inshallah, bearing in mind that this is a two-way process, that we need to seek that clarification from the ulama, and we also need to give them the right information to be able to make that decision. Can I make this proposal that perhaps we collectively work together on this issue more in depth?
Yeah, absolutely. I think we definitely will. And to further reiterate, we have this fantastic palliative care initiative. The chair of the palliative care initiative is Professor Qamar Abbas, so he will, I'm sure, take that on, and you can hear the passion in which he speaks about this subject, and of course delivering that and developing that with our ulama and our speakers. I'm not concluding, don't worry, I'm just addressing that. We have a question from Shenaz Aunty, who...
Thank you, Muhammad Abbas. I think today is probably the best day to mention this, because we've got so many doctors here from the community, and I know getting you all in one place. This is something that Aslim and I, we experience, because when somebody dies in our community, now that the medical examiner is now the middle person, I don't know if it would help if we have doctors in different areas who know the medical examiners personally. So if someone does passes away, could they expedite the process of getting the certificates? Because we end up waiting like 48 hours, sometimes 72 hours for the certificates to be issued so that we can get the burial certificate. So I don't know. I know, I think Nizaba is putting his hand up there because he probably knows somebody in his area in person, but it might help to have, because there are so many of you here today, and if you know the medical examiners, I don't know, Dr. Qamar Abbas, would that work? Like, can a doctor intervene and from a different area?
I'm a GP in Harrow, and
Yes.
those who work in Harrow will probably agree that we actually can get names, email addresses of doctors who are on call. So if there is a long weekend or a holiday weekend, whatever, for every day we get the name and the email address. Can I give you one example? On a Sunday morning at 9 o'clock, a death had occurred. I got in touch with the medical examiner. By 10 o'clock, he has asked me to issue a death certificate.
Wow. But that was Harrow, right?
Yeah, so you're saying extended.
So what I'm saying is, like, do we have doctors in Watford, in different boroughs, who can do the same as what Dr. Mirali could do for this person? Because so maybe we could, I mean, maybe Muhammad Abbas can do this and make a group.
This is very, medical examiners are on call on the weekends. So you should have their numbers to be able to issue the certificate. But there are other practical things which will come into play.
I think the suggestion is really welcome, and I think taking the opportunity to delegate people and find out where they are would be a really valuable resource.
It would, yeah. So if you have a list of the doctors and which boroughs they work in.
Shenaz bhai, ek minute. Shenaz bhai. The thing is, it's only the GP can do it, the GP of the deceased person. If the deceased person is not registered with a community GP, then we cannot do it.
Yeah.
That's simple, yeah? So you can have group of 25,000 of us in that group, but if we are not the GP of the deceased, we won't be able to do anything. That's,
You can't put in a good word either.
No, there is no good word. the only good word I can say is ask all the community member to register with a community GP.
That's it.
Yeah. Then you say, oh, હું મારા community GP પાસે ના જાઉં કે મારી બધી વાત એને ખબર પડી જાશે.
But doesn't that have anything to do with the catchment areas? Like if I live in Watford, I can't register with Dr. Mirali, can I?
You can't. No.
But anyway, I've got.
Please, so essentially, the answer is it's a challenge. If you are registered with someone in the community, that's excellent. If not, then moved to near one of Dr. Dautu's or Dr.
Yeah,
Marley's. Will the Palliative Care Association will fund the transfer?
But my question was, Maulana Sahib, I'm a very simple man, and I understand very simple things. I understood your presentation this morning, and I took that on board. In the morning, you gave the classification of death by our marja. They disagree with brain death, but the marja says if your heart stops beating, if you don't have no pulse, you are dead. That's what I took from this morning, and that's what I'm taking from this session, that a person has died if he doesn't have a pulse. The resuscitation happens after they are dead, not when they are alive, and this is what my understanding is. You don't resuscitate on an alive person. Yeah, you resuscitate on a dead person. The person doesn't have pulse, he's dead, then you resuscitate. So I'm taking this from this morning session. The marja says no pulse, person is dead. Period.
I'll invite both our speakers to respond to this.
I agree that's the case, obviously. But before that, if you have decided this patient had an curable, for example, there's a road traffic accident and somebody has knocked, then you'd want to start resuscitation on them. You're talking about to complete the DNA CPR form for those people who have got less chance or no chance of recovery. My view, so obviously I'm not like answering fiqhi the way, clinically, yes, because it's not just they are dead, it's about the reversibility of it. If it is potential of reversibility, we shouldn't be completing it. If there is no potential for reversibility, then we need to take that into consideration. But from fifth point of view, I'm learning today.
Can you repeat that last part of your question in a simple manner?
So, the presentation that you did this morning.
So what I understood was you said, okay, the person is dead.
Yeah, so the person is dead.
Dead, yeah, okay.
That's khalas. So if the person is dead, and the person has put in writing that when I am dead, do not resuscitate me when I am dead.
Okay.
And the way Ayatollah Sistani has defined death, if there is no pulse. Yeah. So the person says, when I am dead, I don't have any pulse, please do not resuscitate me. Mm-hmm. So that's what I'm taking from this.
According to his fatwa, to give that directive that do not revive me, he said that's not right.
But in the morning you said the definition of death was that the heart has stopped functioning. He doesn't have any heartbeat and pulse, so he is, from that definition, he is dead, right? From this morning. So if I'm saying that when I die, I'm dead because I don't have any pulse, please do not attempt to revive me because I'm only dead according to the rulings.
So,
see, the two things there we discussed. One was the issue that the person was suffering from something which was curable. And, you know, this is where people like Ayatollah Sistani or those who are saying do not sign that, is that you can be revived and, you know, maybe whatever the cure is there. The serious issue was about where there is no cure. Can you write that directive or not? That's the one we are waiting for the question, the answer for that. So if there is a cure, he says you still have to revive that person, if you can. But if there is no cure, that's where we are saying that even in that case, he should have a right to give that directive. And that's where we are waiting for the answer for.
Yeah, we have a question.
Maulana Sahib, I just wanted to ask specifically in relation to the withholding and withdrawing treatment. in what realm does fiqh define reversibility of a condition? So to give a scenario to hopefully help with the question, if you've got a patient who, for example, has a chronic lung condition, comes into hospital with an exacerbation of that condition, requires oxygen, and the amount of oxygen that he's requiring is not sufficient to meet his needs, whereby the next step in the treatment would, for example, be either a type of ventilator or a breathing tube, but the severity of his underlying lung condition is severe to a point where some doctors may think that a breathing tube would be very difficult for him to come off if he is to be put on one. Are you allowed to initiate that decision for him not to have that breathing tube and therefore withhold that intervention, or is this something that is not allowed?
First of all, the issue of whether the situation or the case is curable or not, this is the domain of the doctor. Okay, the faqih only gives you the basic guidelines. So it's not the faqih who is going to decide whether this case is curable or not. If there is no cure there, then withholding that life support is okay. This is what we discussed in the morning.
I think part of the trouble in a doctor determining the possibility of a cure of a condition is it's slightly nuanced. There's not going to be every single condition that has binary yes, no, cure, no cure. So for example, you might have a condition such as heart failure where overarchingly there's no cure, but a person that develops acute heart failure where they have fluid on their lungs, there is potentially a cure where they can take some of the fluid off, and there are several treatment arms in doing that, one of which could be a type of ventilator. So the underlying condition perhaps is not curable, but the condition that they develop acutely might be. So it's not binary where there is a cure, there isn't a cure, but there is a possibility of a cure. Do you then determine the likelihood of that cure and what the doctors are telling you? Is that the remit? Or is it meant to be binary? And if it is the latter, then
let me ask you, what would be your opinion in that sense? Is ventilation itself a cure?
It can be, but equally it might be very difficult to wean someone off that ventilator.
That's why I'm asking that question.
But it's
that not from a lay perspective, when I look at it, I don't look at it at the ventilation as a cure. And so there shouldn't be a problem in withholding from it.
Feel free to repeat what you said if you want to. It's just
I was saying the question was purely clinical, and you are trying to take a course of action to improve, and it may not work. So that's entirely a clinical question. There is no end-of-life issue here. You are in the patient, and you are taking a clinical decision, an entirely clinical decision.
I think one of the important things here is this is a completely different discussion of other scale, because we are talking about, you use the word binary, but we are talking about the discussions which are about palliative care, end of life, treatment, withholding, DNA CPR. But the bigger picture also tells us that hospitals, and I'll be honest because I'm one of them, there's a chaos out there, and in my clinical colleagues, especially the resident doctors are not able to find the right decision in the short space of time. And this is what creates all these frustrations of asking the questions to say, we really do not know, and it's hard for us to take responsibility, which is definitely not their fault at all. Maybe fault of people like me, the senior doctors, to provide them the right support. And this is why these types of questions are generated. But there are different type of discussion than end-of-life care, and which is basically we are not able to find the support in a clinical answer. There's no easy answer to give at that particular time when you're facing that patient and you haven't got the right support. This is where the confusion gets a bit more and more. That's a reality. As I said earlier in the day, quite often we may not have any answer, but we might generate even more questions for ourselves.
There was a time when the process of death was so simple. But the advanced medical science has made it more complicated for us.
Thank you so much. Any further comments or anything anybody would like to share? Anything else at all? This is your moment. Actually, we are at time now. So, with your permission, I'll just say a few final words. A couple of quick housekeeping points. The first one is one of our scholars is traveling to Bab al-Murad afterwards, Wembley, Alperton area. If anybody is going that way, he is hoping for an assisted lift. That would be really appreciated. If you're able to leave your lanyards on the table, as Hujjat is also going for the sustainability element. Of course, the feedback is on the QR code. I wonder if it was okay for me to just summarize some of the things we've learned today. There's some unbelievable learnings that we've taken from today, really. And it's difficult. I'm looking at my notes, and Arif Bhai was saying that some of the questions have come in. What's going to happen with the slides? What's going to happen with the videos? We're recording everything, so all of that information and discussion is being captured. And I'll take that element to be able to signpost you back to our palliative care consultants in the community, not consultants, the champions, who are able to give advice and share resources, and especially as Sayyid Rizvi will be able to, inshallah, when the answer comes, disseminate that information. So we'll wait for that. And of course, a professor is going to be in charge of that work stream for us. So I think that's an opportunity for us to keep abreast of it. And of course, if you're somebody who's not involved and would want to be involved, please find Arif Bhai on the gents side and Sukhair Bhai on the ladies side. Inshallah, they can help. A few things. There's so many things. I have like so much stuff that I'm gonna reread, and I didn't know how to bring it back, but I wanted to cherry pick a few things that I thought were fantastic. We had this concept from the beginning of tawaffa, wafa, the full return, the full review. Sayyid Rizvi outlined for us beautifully, and of course this concept of istishab, which guides us according to how all of the principles are really important. And then we came to Syed Qamar Abbas talking about how important it is that we communicate. And of course, I found this quote so powerful. She felt so good saying it. That was a quote about him asking his mother about what her wishes are. And if you've had the opportunity to talk to someone who is in that stage, and many of you are nodding, saying, ask somebody their wishes, actually is something they want to discuss. So that advanced care planning, even though it sounds scary, is such a powerful thing for us all to be doing, especially when we can honor the wishes of those people. The quote from that lady whose name has escaped me, how people die lives on in those who are still living. Such an important perspective, and hence why I think we have such an important gathering here where we have to learn this concept, because taking that is so key. Of course, on another perspective, we talked a little bit about communication skills, and we talked about a few other elements. But I think for those who have personally been affected, those who are shared their stories. I think, of course, there is nobody better than the words of Sayyidah Zainab salamullahi alayhi when she says, "Ma ra'aytu illa jamila." I think of anything that we could have as our motto, as our slogan, that's one of the most powerful things. And I think, thank you to Sayyid Rizvi for reminding us of that. What have we learned? To ask, to take it, communication as key, to make sure we're always offering the most care we can. But I think, as the troublesome corner in that area has been to us, case-by-case discussion. Really, it's a case-by-case, and therefore, please access our palliative care resources here and in the community to really seek that. I would, if it's okay with you, take one or two more sentences, and then inshallah we'll wrap up. One of them is to say that today we had the opportunity to learn about organ donation, contentious issues, answering questions about grey areas off the cuff. And if you look at the window of time, the time window was about 3 a.m. till midday Toronto time. So I don't think I would be able to answer in that manner and to give all those fantastic different answers from all the different marja'at, to be able to give the history of all those rulings. I really want to thank Sayyid Rizvi for that, and the incredible work. And if you looked at the document he was reading, which I peeked over to, 2006 was when he formulated that. That was when some of us were at medical school not understanding any of this stuff anyway, and 2006. So we are in the presence of people who have really dedicated their life in service to the community. And of course to Professor Syed Qamar Abbas, I think he has taught us many really great things, the importance of consequentialism amongst the history of medicine, which I think many of us were really enamored by your passion for that. And I think, of course, we've also learned about morphine making masterclass, which I'm not sure is necessarily going to be a good thing for us, but we'll take that. And the history of hospices, and of course all of the sort of discussions. In light of all of that hard work, and as you saw the slides, and as you saw the dedication, and even whilst you were all asking questions, I saw Sayyid Rizvi looking through resources, making sure that he's answering questions and doing right by you, and such an important guidance from scholars to make sure we're practicing the right way. Please could I ask us all to recite 3 salawat ala Muhammad wa ali Muhammad. Allahumma salli ala Muhammad wa ali Muhammad. اللهم صل على محمد وآل محمد وعجل فرجهم. اللهم صل على محمد وآل محمد وعجل فرجهم. With that, I would thank you all so much for your participation, humility and learning attitude, and ask that we stand for ziyarah.